Kan jy nie mooi hoor nie?
Ek kan jou mooi hoor.
Daar sê ek kan jou mooi hoor, dankie.
Is net my screen, share screen is nog nie aan nie, maar ek dink hy sal nou aangaan.
Good. I think we're on the air. Good evening to everybody and welcome to our webinar. Hello, Dr. Roux, and welcome to you too. It is a wonderful opportunity and privilege to have you on our webinar tonight. We are looking forward to your talk.
Thank you very much.
I hope you're all nice and warm. We will do the questions after the talk again. If you want to put your questions down, please make sure you put it under question and answer, and then we'll deal with it at the end of the talk. I wonder if we can maybe wait another minute for some more people to enter. I still get some WhatsApps from people saying they can't get in. I don't know where the problem is. I think we've got 43 people. I think, yes. I think let's get started. Otherwise, we're going to be caught up with time. Just to let you all know that I will send you a certificate within the next 2 weeks. If you didn't get it after 2 weeks, please let me know. It might be that we didn't recognize the tablet or iPad that you linked in from. So please, you're welcome to let me know and I'll send it as soon as possible. Thank you very much, Dr. Roux. I just wanted to mention Dr. Roux has a surgical practice and rooms in Northcliffe in Johannesburg. And he also has rooms in Pretoria. He actually resides in Pretoria. And the rooms are on the same premises in Brooklyn, on Murray Street. Am I right, Dr. Roux?
Yes, Murray Street in Brooklyn, close to the university.
Fantastic. Thank you very much. Okay, I think I'll give over to you.
Right. I hope that you can all see my screen, and what I'm going to speak to you about tonight is what's new in the management of age-related macular degeneration. In preparation for what I'm going to say, I want to give you some background information. Now, AMD is the leading cause of blindness in the developed world in people over the age of 50. In the USA, which has 330 million people, 15 million have AMD. That's 2%. And in the breakdown of the type of AMD, 85 to 90% have dry AMD, 10 to 15% have wet AMD, and there are 200,000 new cases per year. 10% of people over the age of 65 have got AMD, and 25% of people over the age of 75. And this goes for all the European countries and also most of Asian countries, although it's slightly less in Asians. Amongst Black people, the prevalence is fortunately very low. Now let's have a look at the risk factors. Age, we've mentioned. Interesting, female gender has a slightly higher prevalence. High blood pressure, high cholesterol, a positive family history, and this is an important one, the next one, smoking. Hyperopia is a bit of a surprise. We always thought that myopia was at higher risk. Myopia has got its own risks for new vascularization in the macula, but that is not related to the age-related type of macular degeneration. And then light iris color. So the bluer your eyes, the bigger the chance to develop AMD. Let's have a look at the pathology. The photoreceptors are reduced in density. That's why patients see more poorly. The retinal pigment epithelium, which I'm just going to abbreviate further in the talk as the RPE, loses its melanin granules. So there's a loss of pigmentation in the RPE. And then there are lipofuscin granules that develop between the RPE and Bruch's membrane. And those lipofuscin granules accumulate to form the yellow dots that we call drusen. Then in the choroid, that is now below Bruch's membrane, the capillaries also undergo involution. In other words, it's a whole cascade of 3 layers that are damaged, actually 4 layers. It's the photoreceptors, that means the rods and the cones, then the RPE, and then Bruch's membrane, and then in the choroid, the capillaries. What about genetics? Patients often ask me, doctor, what is the chance that my children will get AMD? Or they would say, my father or mother lost vision from AMD. What are my chances? Well, let's have a look what is the latest. It still remains poorly understood. That is now the genetics of AMD. There is an interplay between the genetic disposition and high risk factors, as we mentioned just now, smoking, high blood pressure, hypercholesterolemia. In 2015, and it's probably more now, there were 19 genes that were found with mutations that are associated with AMD. The 2 major susceptibility genes for AMD is the CFH, which codes for complement factor H. Now, complement is one of the factors that's associated with blood coagulation. And the second major gene is the ARMS2 gene. And if you have one if you have the CFH gene, you have a 5 to 7-fold increase of getting AMD, and the ARMS a 3 to an 8-fold increase in getting AMD. And if you have both, you have a 50-fold increase in getting or developing AMD. Right, that's just a bit of the background. Now let's have a look at the clinical types. First, there's the neovascular AMD. The non-neovascular AMD. That is a form of dry AMD, but it does develop into, or it can develop into, neovascular AMD. And the hallmark sign of non-neovascular AMD are the yellow spots and dots called drusen. You've all seen them, you know exactly what they look like. Then this can develop into neovascular membrane, which is clinically seen as bleeding and leakage from the abnormal new capillaries that grow in from below from the choroid. And I'm going to show you some nice slides on that. And then the most common form of AMD is the geographic atrophy. And the atrophy that is referred to here is a loss of RPE cells. That is what it is. There's no new vascularization. And it's called geographic because it has the shape of islands or a continent. And that's why it's called geographic atrophy, or abbreviated just as GA. Now let's have a look at some statistics about geographic atrophy. Over 8 million people are affected worldwide with geographic atrophy, and approximately 20% of all individuals with AMD also will have geographic atrophy. So it's not the most common type. Let's just go back to that other slide. I just want to make quite sure. Yes, this slide does not differentiate here in the dry AMD between geographic atrophy and non-neovascular atrophy. That's where that discrepancy comes in. So just to confirm that about 20% of all cases of AMD will be geographic atrophy. And this is what it looks like. You've all seen it. Here is the geography-like or map-like picture. Here's a nice big one, looks like an island. And underlying, we can see the larger blood vessels of the choroid. That is those whitish lines there. And the pigment in between is the pigment in the choroid. As you know, the choroid is dark brown in all people. Whether you have blue eyes or brown eyes, your choroid is always dark brown. And that is the pigment we see interdispersed between the blood vessels. Now, if you have a look at the other geographic atrophy, the most important one is autofluorescence, fundus autofluorescence. And it is a special infrared laser that is on most fundus cameras and OCT machines. And it makes the RPE fluoresce. And that is what we are seeing here on the sides. But when there is atrophy, as you can see here on the colored picture, there is no fluorescence. So it's always very easy to determine whether a patient has geographic atrophy by just doing an autofluorescence. This is a fluorescein angiogram, and these are not new vessels we're seeing here. These are just the capillaries in the choroid that are shining through. We don't see them here because the RPE acts as a filter to prevent the fluorescein from shining through, as you see there. And in the late phase of the fluorescein angiogram, you can see the fluorescein has been absorbed by the sclera, and it now hyperfluoresces in that pattern. Now let's have a look at the OCT. And here we can see normal RPE cells, and then there is a loss of RPE cells. And where there are no RPE cells, there is no vision. So this patient will have a scotoma that size. If he or she looks at the face, it will not be distinguishable. But if the person whose face the patient is looking to lifts a hand, that hand will be visible because it falls on healthy retina. But the central face here will be lost. Good. Now let's have a look at just a more graphic picture of the retina. Here we have the ganglion cells in the superficial retina. we have the bipolar cells in the central retina, and we have the photoreceptors down below. And the photoreceptors rest on this single layer of RPE cells. And look where the drusen forms. They form under the RPE cells. And when we look at it with the fundoscope, we're looking all the way through this, and we see that yellow patch beneath the RPE. When this RPE is damaged, this is what happens. You get a disorientation of the photoreceptors, and you get loss of vision in the foveal area, and you have loss of central vision. Good, let's have a look at the pathogenesis of geographic atrophy. Well, this is also not fully understood yet. We don't know exactly why does it happen, and why do some people get drusen and new vascularization? Why do some just get geographic atrophy? It's likely that it is multifactorial and triggered by intrinsic and extrinsic stresses. For example, cigarette smoking. We know that the nicotine in cigarettes and the other tar-like factors give vasoconstriction. And that vasoconstriction might have an effect on the capillaries in the choroid, thus decreasing the metabolic turnover to the RPE, and therefore contributing to atrophy of the RPE. And in particular, it's the oxidative stress caused by the high metabolic demand of photoreceptors, the photooxidation, that means the burning of oxygen. Our body burns oxygen in every cell, and environmental products of oxidative stress that can trigger inflammation via multiple pathways, ultimately leading to loss of and death of photoreceptors and the RPE and the choriocapillaris. So I know these words don't really say much to you, but suffice to say it's not clearly understood, and we think that the oxidation is a major role player, and that's where antioxidants come in, which we'll be talking about a little bit later. Right, so just looking at the geographic atrophy in a little more detail, recent studies indicate that geographic atrophy may be due to deficiencies in blood flow. Well, we've mentioned that with the cigarette smoking. Regions in the choriocapillaris which had less blood flow were more likely to generate and become geographic atrophy. So there is some scientific proof that this is due to a decrease in the blood flow of the capillaries in the choroid. And since the choriocapillaris is the main blood supply of the retinal pigment epithelium, it is leading some to believe that geographic atrophy is primarily an ischemic disease, like a heart attack is ischemic disease. Okay, now we come to the next part of the talk, which is the non-neovascular AMD. And I think you will agree with me that this is the most common type we see. And we see it in the form of the drusen. And here is a color picture. Here are small discrete drusens. There's one big large one. There's another large one, etc. And they, as I mentioned before, they are located between the retinal pigment epithelium and Bruch's membrane. And Bruch's membrane separates it from the choroid. It is a lipid-rich material. That's why it's yellow. You all know that fat is yellow. And the Bruch's membrane is thickened in some areas and thinned in other areas. And then the overlying photoreceptors are also affected and associated with mild to moderate vision loss, decrease in contrast sensitivity in color vision, and impairment of dark adaptation. Patients will typically say, "Doctor, I walk into the house and it takes me a long time before I can see properly in the house." And here we can see, once again, on this image, the RPE cells there, loss of photoreceptors in the retina, and the drusen between Bruch's membrane and the RPE. And these are the capillaries of the choroid. Now we get to the main culprit, which causes the most damage, and that's neovascular age-related macular degeneration. And it follows on drusen. Most people will first develop drusen, and through those drusen or next to them grow new blood vessels from the choroid. And those little blood vessels are weak, they fracture easily, and therefore, and then they start bleeding, as you can see on this photograph in the right upper corner. This was probably just a small little neovascular membrane, and the capillaries ruptured, and it caused a large hemorrhage. This blood can absorb again, but the membrane can still leak, and it leaks primarily two things: fluid and lipids. And the lipids look exactly the same as the lipids in diabetic retinopathy. Looks like hard exudates. Here on this lower photograph, we can see here that the capillaries have grown through the retina and have now caused a scar here under the retina. This is what it looks like on OCT. We can see the normal retina here. We can see the normal RPE over there. And here is the neovascular membrane. It's under the RPE. That's the RPE layer there, although the RPE here has been disturbed. And we see this black fluid level. When you see black on OCT, it's fluid. Just as the vitreous up front here is black, that's what it looks like on OCT. Here's another example where we see a large membrane under the RPE, and it's leaking fluid, causing these little cystic swelling in the retina, and also elevating the retina. Now I just need to move my photograph out of the way so that I can see these lower pictures. Here's another membrane that has grown through, and there's another example. And if you like to remember, this looks like the McDonald's. You see the little M's there. That's also typical of a membrane. Right. Now, that's all I'm going to say about the types of age-related macular degeneration. What your patient and what my patient is most interested in is what can be done for them. And I would typically advise a patient who comes in with drusen to start taking a antioxidant eye or ocular tablet. There are a number on the market. What we are looking for in that tablet is the following. We are looking for vitamin C. We are looking for vitamin E. we want lutein and zeaxanthin. We need zinc. I'm sure you're all already drinking zinc for the COVID pandemic, and you need copper. And this is the formulation that was used by the AREDS 2 study, the age-related eye disease study, which was a multi-center study and which evaluated the value of giving antioxidants to patients with macular degeneration. So it's still worth also giving the patient a Amsler grid. Although we have so many square things in our homes, the picture frames on the wall, the doors, the windows, etc., that it's, in my opinion, not so important to give an Amsler grid, but it's something for the patient to take home and to remind him or her that they have to look at this grid. I tell my patients once a week, but it can be less, it can be once a month, because I know they are going to look for that little grid as soon as they see that the image in the mirror has been warped. Now, let's look at the outcome of the AREDS 2 study. There were 4,000 participants, which is a big study. And the findings were that there was a 25% reduction in risk of developing advanced disease over a period of 5 years. And it was more than placebo. In other words, it does seem as if antioxidants play a role. And there was a 19% risk reduction of moderate vision loss of more than 3 lines of visual acuity. So the more advanced the disease, the more likely you were to benefit. The less disease, the less likely you were to benefit. So if your patient has only got 1 or 2 little spots of drusen, rather just advise them to eat healthy. Fresh fruits and veggies, the green leafy vegetables in particular, like spinach and broccoli, and follow them up once a year. And if it progresses and they get more and more drusen, then I would start to advise them to take one of the products that are available in our pharmacies. Here you can see the results of the AREDS study in a graphic form. You can see at the top is placebo in purple. They had a 28% chance of progressing to advanced AMD. And if you took antioxidants and zinc, it made a big difference. And if you combine the two, antioxidants and zinc, you only had a 20% chance of developing advanced AMD. So I think that is enough proof that we can advise our patients to live healthily and to stop smoking, to take their blood pressure medication regularly, and to take their cholesterol medication regularly if they are on that. Now, as ophthalmologists, we are this is what we have to offer for patients with new vascular age-related macular degeneration. And the group of drugs are called the VEGF inhibitors. And VEGF stands for vascular endothelial growth factor. This growth factor is a protein that is made in areas of damage and which facilitates new little blood vessels to grow. So if you cut your hand by accident with a knife in the kitchen, it's going to become red and inflamed, and then new little blood vessels will start to help that incision to heal. And so VEGF is all over in our body, but it's also in the retina. And it is amazing how effective it is to inject an anti-VEGF factor. It is an antibody. It is derived from mice. So it's called a murine antibody. And it binds to the VEGF, and the new blood vessels disappear, all within a week, sometimes even shorter. The anti-VEGF medications in South Africa that are available is Avastin. This medication was actually developed for colon cancer. But for colon cancer, it was given in much higher dosages. And what it does to colon cancer, it makes the new little blood vessels in the cancer shrink. And then the cancer shrinks, and then the surgeon can do a more simple excision of that diseased part of the colon. And it is during this time that they coincidentally saw, but people's AMD got better, or if they were hemorrhaging in the eye, the hemorrhages went away. And then the ophthalmologist picked up on that. Until today, this is the most common drug injected worldwide as an anti-VEGF. The Lucentis, or ranibizumab, is the second most common medication. And this is not an off-label medication. This was designed specifically for AMD, made by the same company, by the way, Genentech in the USA. But it costs about 20 times that of Avastin. And so the medical funds in South Africa are reluctant to pay for that, but they will pay for it if we tell them that the Avastin has not had an adequate effect. Then they are willing to pay for Lucentis. And the same goes for Eylea. All three of these drugs are available in South Africa. And each one works slightly differently. And if the one doesn't work, you can upgrade to the next one. The brolucizumab, or Beovu, is a new medication that is now available in the USA and I think Europe as well. It hasn't been launched here in South Africa yet, but it is also an antibody, and its main advantage, let me see, I might have a slide on that. Its main advantage is that the intervals of injection are more spaced out. In other words, to put it in real terms, Avastin, let's go back to the previous one. Avastin is given monthly. Lucentis, after the first 3 doses, is given 2 monthly. And Beovu is going to be given 3 monthly, which only means 4 injections versus Avastin, which is 12 injections per year. That is, if you need so many injections. This is what it basically looks like. We do it in the rooms. We go through the posh plana with the syringe, which is loaded with the Avastin or the Lucentis, and you inject it straight into the vitreous. It's not painful to the patient because we use topical anesthetics, and then we use an injection of local anesthetic, which numbs the area of injection completely and the patient doesn't even know you've injected it, except that they see the little bubbles entering the eye. So for Avastin, this is our regimen, and which I think most practices use, monthly injections. We normally give 3 to 6 injections, and thereafter we give only if there are new hemorrhages or new exudates or new subretinal fluid. And we check these patients every 6 to 8 weeks, and we do an OCT. And if there's anything that has changed, we give another injection. So I think I've mentioned this. The advantages is that it's only going to be 3 monthly. These are just the studies showing the effect of the brolucizumab compared to Eylea, and we can see they are pretty similar. I'm not going to bore you with that. Okay, so that's the real world AMD. Now I'm going to just share with you a little bit of new kids on the block. The first one is the embryonic stem cell therapy, ESC therapy for geographic atrophy. Remember, I did not mention anything for the treatment of geographic atrophy. Antioxidants don't appear to work for that. And here is something now for geographic atrophy. And what is done, embryonic cells are taken and they are put in a growth fluid, and the cells start to divide and increase. And then the laboratory makes these embryonic stem cells to differentiate into RPE cells. How they do it, I've got no idea. But it is amazing technology. And then these cells are isolated and concentrated and injected under the retina, between the retina and Bruch's membrane, where the RPE cells would normally occur. And this is what it looks like. Here's your normal retina with the choroid, RPE, and the photoreceptors. And then you have death in AMD. And here now is a needle put in beneath the retina, and these cells are injected, and with time they start to orientate themselves in the right direction, because they have a top and a bottom and a left and a right, and they must be in the right orientation. And they reorganize themselves, and there is some evidence that it actually works to some degree, I would say. So the company is called OpRegen, and they had 4 patients that they treated. And this actually improved the corrected VA up to 1 year from the injection. So there was a lasting effect, which is actually amazing. These cells were not were accepted by the body and not rejected like you normally get from any foreign organ that is placed in your body, like a new heart or a new kidney. You have to have immunosuppression treatment to prevent your body from rejecting the new organ, but here it was not necessary. So this pooled data demonstrates a significant and greater than 10 letter sustained visual acuity improvement. So 10 letters is about 2 lines on the EDTRS chart, which I think is quite significant. Good. Now the next topic I just want to mention, and we're going to finish with this, Louise, I hope we still have enough time, is that of the intraocular lenses that are available worldwide for age-related macular degeneration. And these lenses basically are just tiny telescopes. And there are quite a number of them. There's the INT, the IOL VIP system, the IOL AMD system. And it is just basically a Galilean type of telescope, but tiny, and it is implanted in the place of your normal crystalline lens. So it has 2 optical elements with high positive and negative powers, and used in combination with the cornea, you get a magnification of the image. So it's not treating the AMD per se, it's just giving you a bigger image. And this is what the INT implantable miniature telescope looks like, and it gives a 2.5 image enlargement, as you can see here. The same goes for all of these lenses. Their designs are sometimes slightly different. This one has got the least enlargement, only 1.3, so that's not much help. Here's another one, the Lipschitz macular implant, gives a 2.5 magnification, and the Scarieth macular lens, a 2 magnification. These lenses sound exciting, but I was approached to try them out by one of the companies. And the problem was that it was extremely expensive for the patient to buy this lens. It was not part of a study. They were basically trying to sell the lenses here. And that is the first problem. The second problem is that these patients have to undergo a strict rehabilitation program. You start by 2 weeks preoperative training with a handheld magnifier, and you have to try and train your eye that is now looking in the distance to use the magnifier, and you must suppress your other macular degeneration eye that is seeing a normal periphery. And so it is a matter of training your brain to choose the better image. Then there's a 3-month post-operative rehabilitation training. There are 5 30-minute training sessions per week for 12 weeks. And some cases need up to 6 months of training. So it's not that easy for them to adapt to this. And as far as I know, no one in South Africa has started using these lenses. So in conclusion, about the lenses, there is no single ideal lens for the use in existing AMD, and the outcomes reported so far are variable and most probably have only been focused on short-term outcomes. And with that, I think we are done with this part. You are most welcome to ask any questions should there be.
Thank you very much, Dr. Roux. Under the question and answer, we have one question. What schedule is the VEGF inhibitor?
I'm not exactly sure. If you are a pharmacist or your spouse is a pharmacist, you do need a prescription for it. but we buy it from the wholesalers, and I don't think it is available over the counter. It's not something that you can drink. It's got to be injected, and we get it from the major wholesalers that sell eye drops. In the case of Avastin, we get it from a compounding pharmacy. That is a pharmacy who actually puts the medication into a syringe for us, so that we can inject it, because it is sold as a vial, and you have to stay in a sterile way, transport it from the vial to the syringe. And there are medical legal issues about that, and we normally do it in theatre. The nurses in theatre do it for us, or we get it from a compounding pharmacy. I hope that answers the question. As you all know, anything Schedule 1 or 2 is over the counter, and from Schedule 3, like an antibiotic, up to 6 are only per prescription.
Thank you, Dr. Roux. There's one. You can also see it under the question and answer department at the bottom of your computer. It says in GA, how long does it take for the generation to progress to the stage you showed in your initial slides?
Well, that's a very good question, and it starts small. Let's say the size of a pinhead, and then it grows gradually bigger and bigger. And that period would be probably 2 or 3 years, from the size of a pinhead to the size of half of the macula.
Okay, then excluding medical aid payments, how do you decide which anti-VEGF is best for the patient?
Well, we always start with Avastin because it's the medication with the most experience. And if finances were not an issue, I would use Lucentis as my first choice. And if I don't get a good enough response after 3 treatments, I might move on to Eylea.
Thank you. Why is omega-3 removed from the antioxidants recommended in the ARED study?
Yes, that was part of the AREDS 1 study. So there were actually 2 studies, AREDS 1 and AREDS 2. Sorry. And they found no benefit by adding omega-3. So statistically, it was not beneficial to add it, and they took it out for that reason.
Christine wants to know, when are we likely to have ESC available to our patients?
Oh, that's a very difficult question. At this stage, it is, they are now in the phase 3 studies. That means they've tested it on volunteer patients. Those were those 4 patients. And normally it takes about 10 years before a medication or a cell line like the embryonic cells, it takes about 10 years to get onto the market. So my guess is 10 years.
Thank you.
It's a long time.
Yes, they could be dead by the time. if they haven't, if they're already in old age. Is vaping a risk factor?
Just repeat, please, Louise.
Is vaping a risk factor?
I don't know enough about vaping. If it gives vasoconstriction, and let me ask any vapor, this question. If you feel it affects your mind, in other words, you're feeling slightly lightheaded or something like that, there is probably some vasoconstriction action, and that would, in my opinion, could affect the blood supply in the choroid. But if you vaped a couple of times or you vape once a weekend, I think it is a matter of how much and how often you are using a recreational drug like that.
Good. And then how common is endophthalmitis following anti-VEGF injections?
That's also a very good question. I didn't look into that. In our own practice, we've had a couple of patients, and by a couple I mean maybe less than 5, and this is over a 10-year period, which had a reaction to triamcinolone. Now, triamcinolone is not an anti-VEGF, it is a steroid. And we give those intraocular steroid for other conditions, for example, diabetic macular edema and macular edema following venous occlusions. And sometimes I use it in a patient together with Avastin to decrease fluid in the retina. So we think that the triamcinolone, that some patients are hypersensitive to it and react. So it's not an infection like a true endophthalmitis. We call it a sterile endophthalmitis. In other words, there is exudation of white blood cells. You can actually have a hypopion, but the eye is not red and it's not painful. So my answer is that it is extremely rare, but that I'm sure it has occurred. Thinking back in our practice, we have had maybe 2 cases that I can recall that we thought was an endophthalmitis after Avastin. We did vitrectomies on those patients and they retained their vision. But yes, there is a risk, but it must be a very small risk. My guess is 1 in a 1,000.
Just a question for myself, Doctor, is some doctors prefer to do the anti-VEGF injections in theatre. Some do it in the rooms. Maybe could you just tell why that is the case?
Yes, we would like to do it in theatre, all patients in theatre, but some medical funds don't want to reimburse the doctor or the hospital, and that's why we do it in the rooms. And then they reimburse the full amount because it's much cheaper doing it in the rooms. There's no theatre fee. Whereas in theatre, you have a 20-minute theatre fee, which could be a couple of $1,000.
Thank you. Can there be visual changes on Amsler grid before noticing any changes on the retina?
I guess that is possible. And although, let me put it this way, the aim of the Amsler grid is to pick up metamorphopsia, in other words, warping of an image. And it is possible that you can have an early neovascular membrane under the RPE, which is starting to lift the retina, but it's not visible on ophthalmoscopy. It will probably be visible on OCT though. So yes, I think you can have early changes of AMD which show up on the Amsler grid, but is not visible with fundoscopy. Fundoscopy is just, the resolution is just not good enough. Whereas OCT at this stage with a resolution of 5 microns, that's the size of a red blood cell, the resolution is much more superior than the clinical observation.
Thank you. Is there a difference between ocuvite complete and ocuvite lutein? Are there risks associated with any of these?
As far as I know, the ocuvite complete has got lutein in. I must admit I do not know the exact difference between ocuvite complete and ocuvite lutein. With the AREDS-1 study, they found that now the AREDS-1 formulation had beta-carotene in it. And they found an association with ingestion of beta-carotene and lung cancer in patients that were smoking. And so the beta-carotene was dropped completely. Now, I will have to go and have a look at what is exactly in those two compounds to say what is the difference. But both are available and both will be useful.
Thank you. Is there a link between high cholesterol and drusen and AMD?
As far as we know, there is no link. In other words, if you've got drusen and you take hypercholesterol treatment, your drusen will not become less. So there is no direct link between the two.
Thank you. If Amsler distortions are noted, must only a few drusen spots, sorry, I just want to check here, must only a few drusen spots are seen? Would you advise that we just monitor the patient or should we refer them?
Yes, if it's just a few drusen spots and they are not in the fovea, in other words, the vision is not affected, I would just advise, if I were an optometrist, I would advise the patient a healthy lifestyle, cessation of smoking, and the blood pressure and cholesterol medication if they were on it. If they weren't on it, they should have it checked.
Is the decreased dark adaptation an early indication of AMD? If no, OCT is available and no other signs, precursor C noticed?
Yes, it's a slightly difficult that I've seen over years that complain of decreased dark adaptation. And I'm never, and when I examine the eye, I don't see anything wrong. And it can also be in younger people. So to me, that is a very vague symptom. But if it's the right age, if there are one or two drusen visible, and they complain of decreased dark adaptation as a new symptom, I would take that more seriously, and I would probably start them on antioxidants.
Okay, if Amsler distortions are noted, but only a few drusen spots are seen, would you advise that we just monitor the patient or should we refer them?
Yes, I answered that just now, and I would say you can just follow them and only send them if they have decreased in central vision.
What are the effects of alcohol consumption on development of AMD?
As far as we know, there's no direct correlation between alcohol consumption and AMD. In other words, if you took a cohort of alcoholics, say at the AA clinic, and you check them for AMD, there would not be an increase rate of AMD, except if their nutrition was poorer because they're drinking, they're not eating, and they often are smokers. So alcohol per se does not appear to give AMD. Alcohol in general gives vasodilatation. So if someone has been drinking too much, he might be slightly red in the face and the nose will be a bit redder, showing that there is vasodilatation. That is the opposite that you get with vasoconstriction like smoking. So I think it's safe to enjoy your wine.
What is the risk of AMD with the use of fluoroquinolone?
Yes, it is very low. There have been many studies about the risk of a chloroquine maculopathy. It's not, in fact, an AMD. It is a maculopathy. So chloroquine or hydroxychloroquine, the difference between the two being that hydroxychloroquine has far less chance of causing a chloroquine maculopathy. But unfortunately, it's not available in South Africa. So if you are drinking Nivaquin, it is a normal chloroquine. And there are many patients with rheumatoid arthritis and lupus erythematosus that are on a daily tablet of chloroquine. And the consensus is that after 5 years of taking it every day, you start to develop a chance of having a maculopathy due to the chloroquine. So it's very safe to use concerning any changes to the retina. But it can. I've seen patients that have been on chloroquine for 10 years, which have depigmentation in the fovea with a mild loss of vision, say down to 618 or 615, that type of vision loss. And then the drug.
They mentioned fluoroquine.
I'm not aware of the. I think they wanted to say chloroquine. I'm not sure.
I just wanted to double check. If
Yes.
we are not right, please, whoever sent this question, you're welcome just to rectify us.
Yeah, Louise, there is a drug called a fluoroquinolones. Now,
Yes.
fluoroquinolones are antibiotics.
Okay.
And they are typically given for a tonsillitis or a otitis media or, sinusitis and so on.
Okay.
And, the fluoroquinolones can soften Bruch's membrane, which can lead to a hemorrhage. So if that person was referring to fluoroquinolones, then there is a possibility, but it's extremely rare. You're probably more likely to tear your Achilles tendon than to develop a hemorrhage in your eye. I don't use fluoroquinolones.
Thank you. What is your antioxidant of choice?
Well, at this stage, I've checked my retinas. There are no drusins. There are no geographic atrophies. So I just have a healthy diet. I eat a fresh salad every day with things in like tomato and and green pepper and red pepper, etc. I use some garlic. Whenever we cook, we use garlic, which of course is an antiplatelet effect. So it prevents clotting. And then we like to have our boiled spinach or broccoli, and we have that a couple of times a week. And so far, that is holding out for me. But every patient is different. And someone in their 50s might already have some drusen. And if they have a family history, I would tend to put them on an antioxidant tablet.
Good. Have you seen a connection between warfarin and AMD?
No. The only connection that that there could be is if you have a hemorrhage under your retina and you're on warfarin, that hemorrhage can be bigger than it would have been had you been off warfarin. So I would ask the patient to contact his or her physician and to ask if they can stop the warfarin for a couple of months so that we can treat the new vascular membrane and the hemorrhage and wait till it subsides. And then they can continue their warfarin again. It all depends what they're using the warfarin for. If it's for a deep vein thrombosis, it's not so bad. Your chances of getting a serious complication by stopping the warfarin is low. But if you have atrial fibrillation or you have an artificial heart valve, you cannot go without your warfarin. And in those cases, you will just have to continue your warfarin. There's no other option because stopping the warfarin could have serious consequences.
Dr. Roux, it seems like it's the only questions we have, which I think were quite a few. And we got quite a few compliments for an excellent talk. Thank you very much. And all of you have a wonderful evening, and we'll see each other with the next webinar. And remember, your certificates will be sent in the next 2 weeks. Good night, all.
Louise, and good night to everyone.
Thank you very much. Bye-bye.